Welcome back, neurophiles. This is, and forever shall be, Dr. Ribbonick. Today we will review seizures and epilepsies. Wait a second, what am I doing? I'm a stroke neurologist. Why am I talking about epilepsy? I think I'm gonna need some help on this one. But before I introduce our guest... This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. We have no relevant financial conflicts to disclose. As always, the case used in this talk was modified for teaching purposes. So, we will introduce a case, then discuss the chief complaints with which seizures present and their differentials. Once we are convinced that our patient had a seizure, we will then review how to determine the type of seizure. Majority of seizures in people aged over 25 are usually focal seizures, which means they can be localized to a particular area of the brain. Localization of seizures has very real implications on treatment. We will then need diagnostic testing to confirm our suspected localization and predict the risk of seizure recurrence. And speaking of recurrence, a high likelihood of seizures without provocation essentially translates to the diagnosis of epilepsy. We will review types of epilepsies, their etiologies, and several epileptic syndromes. Diagnosing a patient with epilepsy means that a high risk of future seizure is expected, which likely means anti-seizure drug treatment. We will review some of the major side effects and principles guiding the choice of anti-seizure drugs. Sometimes seizures become uncontrolled and turned into status epilepticus. In this next section, we will learn how to terminate status with extreme prejudice to prevent brain damage. A significant number of patients develop epilepsy that is refractory to anti-seizure medication. So here, we will proceed to a discussion of surgical treatments. And we will conclude by reviewing an approach to a patient with seizures. This is the section that hopefully will bring it all together. Use the chapter markers to jump directly to any of these sections. Throughout this talk, we will be asking questions, so feel free to yell out answers at the screen. Now that we got the fine print out of the way, let me hand over the reins to Dr. Helen Hun. Dr. Hun, take it away.
Thank you. Hello, I'm Dr. Helen Hahn, and I'm an epileptologist in the Department of Neurology at Rutgers Robert Wood Johnson Medical School. Let's start with a case. Miss A is a 35-year-old previously healthy right-handed woman who presented to the hospital for 1 minute of generalized shaking. The patient tells you that she does not remember anything related to the event. She only remembers waking up in the hospital after feeling weird. Oh, and she says the inside of her mouth is painful. She is accompanied by her boyfriend who saw what happened. He tells you that she initially looked confused and started making sounds with her mouth and pulled at her clothing. She then looked to the right and her body started shaking. She could not be woken up until she arrived at the hospital. This was the first time something like this happened, but she admits to having one episode of feeling weird, like she was in the exact same situation before. She then smelled burning tires and tasted iron in her mouth, felt slightly confused afterwards, and needed some time to recover. The vital signs are normal, and the patient is afebrile. The patient is awake, alert, and oriented without any language issues. Cranial nerve, motor, coordination, and sensory testing was normal. She has a laceration on the left side of her tongue. So in summary, this is a 35-year-old woman who presented with 1 minute of generalized shaking, preceded by lip smacking and automatisms. Exam only showed a tongue laceration. She was also confused, and it took some time to return to her normal mental status. What is the pathological differential diagnosis? Seizure? Sure, that is at the top of our list, but also convulsive syncope, panic attack, psychogenic non epileptic event, and movement disorder, like tremor. How did we come up with this differential? Better yet, how do we decide that seizure is most likely? Well, the definition of a seizure is a sudden change in consciousness, behavior, or movement of the body. This is caused by electrical hypersynchronization of neuronal networks in the cerebral cortex. And the sudden change tends to be transient. Seizures often present with two major chief complaints: motor dysfunction and shaking, which can present during sleep, and non motor symptoms like language, vision, and sensory changes, confusion, loss or alteration of awareness, loss of time. Now, the problem is that none of these symptoms are particularly specific for seizure. Motor dysfunction and shaking can be a symptom of convulsive syncope, movement disorder like tremors and ataxia, panic attacks and anxiety, transient cerebral ischemia, and psychogenic non epileptic events, which are seizure like attacks, perhaps triggered by a psychologically traumatic event, but without evidence of abnormal brain electrical activity. Seizures can happen during sleep, but so can other abnormal movements. REM, sleep behavior disorder, is a sleep related disorder where normal suppression of motor activity does not occur. Patients act out their dreams, which may also be seizure like. Transient non motor symptoms are common to migraines with aura, typically visual phenomena, and cerebral ischemia. Transient alteration of awareness and confusion can be caused by disorders like transient global amnesia, transient memory dysfunction, probably due to hypoperfusion of the hippocampus, syncope, and rarely migraine or transient ischemia affecting reticular activating system pathways. So, not everything that causes transient neurological dysfunction is a seizure, and generalized shaking is not the only way a seizure can present. Most seizures in people aged over 25 begin in a focal cortical area, so patients experience auras. Auras are brief focal seizures with preserved awareness. Some examples of auras include experiential phenomena like deja vu, epigastric sensations like butterflies in the stomach, and sensory phenomena like abnormal smell or taste. Most seizures have a clear and abrupt onset and rapid progression of symptoms over more than 10 seconds. A perfect example is the spread of activity between contiguous cortical areas responsible for motor function. Twitching of one side of the face may evolve to shaking of the arm and then the leg. This is known as the Jacksonian march. In general, most seizures end spontaneously within minutes. After a seizure ends, there is a period of confusion and lethargy that lasts 10 to 20 minutes. Manifestations of this post-ictal period may also include focal neurological deficits and a lateral tongue bite. So, why did we think our patient had a seizure? Well, the aura of lip smacking and hand picking, the ictus of generalized shaking that stopped by the time the patient was brought to the ED, and postictal confusion with evidence of lateral tongue bite. While this patient did not have any risk factors for seizures, some risk factors to look out for include structural brain lesions due to prior strokes, traumatic brain injury, meningitis, or encephalitis, prematurity and developmental delay, family history of epilepsy, and childhood febrile seizures. Oh, and certain medications and illicit substances can also lower seizure threshold. Note that I said lower the seizure threshold, not cause seizures. For most drugs, the magnitude of seizure risk is likely low, and often an underlying predisposition is necessary to actually seize. So we decided that our patient had a seizure. And what is the most likely seizure type? The type of seizure is important because it will guide workup and treatment. That brings us to the International League Against Epilepsy seizure classification. Seizure classification depends on defining where in the brain the seizure started. You have two choices, focal and generalized. Focal onset means that the seizure starts in one brain region, and generalized seizures originate at some point within the brain, probably thalamus, and rapidly engage bilateral brain networks. A small proportion of patients have unclassified or unknown onset, which usually means we need more information. Seizures are stereotypic. In a particular patient, they happen the same way because electrical activation follows the same network. So you'll likely get more opportunities to define the episodes. Focal onset seizures may impair awareness, present with motor symptoms like automatisms. These are semi purposeful hand and finger movements like picking at clothes. And non motor symptoms like funny smells, intense fear, or behavioral arrest. Generalized seizures are usually tonic-clonic, the shaking that anybody would notice. Patients abruptly lose consciousness, the muscles of the chest, back, and limbs stiffen into a tonic phase, and after approximately 1 minute, the limbs begin to jerk and twitch for an additional 1 to 2 minutes, the clonic phase. Tongue bites can happen during this clonic phase, producing frothy and bloody sputum. After the seizure, patients have postictal lethargy and confusion as the brain slowly recovers. The most common non-motor generalized seizure is absence. It's an episode of sudden, profound impairment of consciousness without loss of body tone or falls.
To the dark, hide away. They say no one will love you as you are, but I won't let them break you down to dust. I know that there's a place for us, for we are glorious. When the sharpest words wanna cut me down.
Patients suddenly stop what they're doing, begin to stare motionlessly, and stop responding for about 10 seconds.
This is me.
You may notice a bit of a conundrum. During an absence seizure, people stop responding and stare motionlessly. But during a focal onset seizure with impaired awareness, people also stop responding and stare. How do we tell the difference? Focal seizures with impaired awareness are usually less frequent, several per month versus multiple per day for absence. Last longer, minutes versus less than 30 seconds. And have a postictal phase with confusion, lethargy, and language dysfunction if the dominant hemisphere is involved. After an absence seizure, patients typically go back to what they were doing without a postictal state. Focal seizures more frequently present with automatisms, like the finger picking, and focal seizures may evolve to bilateral tonic-clonic seizure. Bilateral tonic-clonic activity? Isn't that a generalized seizure? Confused? Well, focal seizure activity may ultimately spread to involve the entire brain. At that point, patients will lose consciousness and experience tonic-clonic activity of both sides of the body, just like a generalized seizure. Focal seizure activity that progresses to the whole brain is called focal to bilateral tonic-clonic spread. So, bilateral convulsions do not necessarily exclude focal onset of a seizure. In fact, for most people over 25 with bilateral convulsions, a seizure begins in a focal brain area. This is where a good description of auras and ictal and postictal symptoms is extremely helpful. So, our 35-year-old woman, presented with feelings of deja vu, funny smell, taste, followed by alteration of awareness, followed by lip smacking and hand picking, followed by looking to right side, 1 minute of generalized shaking, and 30 minutes of confusion and lethargy. Exam showed a lateral tongue bite. What is the most likely seizure type that our patient experienced? Yes, this is an awesome description of a focal onset seizure with impaired awareness and automatisms, and those feelings of deja vu and olfactory and gustatory hallucinations. They're probably auras, basically focal non-motor seizures. But what about the shaking of the entire body? Yes, focal onset seizures can spread to bilateral tonic-clonic activity. So, we're convinced that our patient suffered a seizure. We're also convinced that the seizure was focal in onset. Since there's a seizure focus, there's a good possibility for localization. Where do you think the seizure started? Hold that thought. Time for a little bit of anatomy. Imagine that you're looking at the brain in the sagittal view from the midline and laterally. The leftmost slice is at the midline, and the rightmost slice is lateral left hemisphere. Since the temporal lobes are the most frequent site of focal seizures, let's start there. Activation of the insula results in abdominal symptoms, such as rising epigastric sensation or abdominal discomfort. Once the medial temporal lobe is activated, a patient experiences gustatory and olfactory hallucinations, metallic taste, burnt smell, and experiential phenomena such as deja vu. The symptoms then progress to behavioral arrest, automatisms, and impaired awareness. Now, say the seizure begins in the frontal lobe. Singular gyrus is part of the limbic network, so activation of prefrontal area and the cingulate can cause intense fear and screaming. Seizure activity in supplementary motor and premotor areas generate complex movements like cycling, rocking, and grimacing. Frontal eye fields control horizontal eye movements, and activation here directs the eyes contralaterally. If seizure activity extends inferiorly to Broca's area, patient may have expressive language difficulties. Activation of precentral gyrus results in simple tonic-clonic movements. Seizures in the occipital cortex are rare. They present with simple visual phenomena, flashing lights, geometric shapes, visual field defects, or more complex visual hallucinations and illusions. Got it? Let's put that to the test. Where did this seizure originate? This seizure begins with an aura. The patient is seen reaching for the button, then behavioral arrest, head and gaze deviate to the left, clonic movements begin in the left face, spreading over the left arm as the seizure spreads over the right primary motor cortex. This is called the Jacksonian march. Left arm extends in a fencing posture. This is a complex motor movement indicating involvement of the supplementary motor area. And unfortunately, seizure then spreads to the contralateral hemisphere and becomes bilateral tonic-clonic. This seizure likely started in the frontal lobe. Now, what about this seizure?
Hi, did you press the buzzer?
This patient recognizes an aura of deja vu and epigastric rising sensation. He presses the button to mark the onset of those sensations.
Okay, you think you're not seizure. Okay.
Oral and manual automatisms start. He smacks his lips, and picks at his clothes with the right hand. At this point, he still retains enough awareness to say, I think I'm having a seizure.
Good, Matt. Thank you. You can put it down. Okay. What's your first name? What's your first name? What's your name?
Then behavioral rest and unresponsiveness. As the seizure spreads to the frontal lobe, the patient turns his head and eyes to the right, vocalizes loudly,
All right.
and then develops tonic posturing, followed by chronic movements.
He's biting his tongue. Blinking. All right, Matt.
Which eventually involve both sides of the body as the seizure spreads to the contralateral hemisphere.
Can we time how many minutes already, please? All right, Matt. Matt. Okay, stopping now. Stopping.
The nurses try to suction the patient's secretions and to turn him on his side to avoid aspiration. Postictally, the patient remains somnolent and unresponsive.
All right, Matt.
This seizure likely started in the temporal lobe. Separating symptoms into neat boxes is helpful for learning, but the previous video reminded you that seizures can spread between brain areas. Occipital seizures can become temporal, temporal seizure can become frontal. All that to say is that the first symptom the patient experiences can give you a lot of information about the part of brain in which the seizure starts. Let's get back to our patient. She experienced déjà vu, burnt smell, and metallic taste. She then presented with abrupt alteration of awareness, followed by lip smacking and hand picking, followed by looking to the right side, followed by generalized shaking. What is the most likely localization of her seizure focus? Yes, left temporal lobe. So what should we do next? The ultimate goal of seizure management is to stop the seizures. But to decide if and how we should treat takes a bit of work. To help us decide if to treat, we need to estimate risk of future seizure recurrence. To help us decide how to treat, we need to look for a causative brain lesion. And the first step of estimating the risk of seizure recurrence is to decide if the seizure was unprovoked or provoked, a symptom of some acute systemic illness or brain insult. A long list of acute illnesses can lower seizure threshold. Drugs like antibiotics and illicit substances, acute strokes, toxic metabolic derangements like hyponatremia, acute traumatic brain injury, meningitis, and encephalitis, and just having fever in general. Anything that can affect the cortex can probably result in a seizure. These acute symptomatic seizures usually have a low risk for future spontaneous seizure recurrence. Presumably, once the acute illness is treated, the seizure risk goes down. Now, unprovoked seizure is a completely different matter. Chances are, whatever dysfunctional or lesion brain network produced the first unprovoked seizure will produce future events. So, was our patient's seizure provoked? Not likely. Our patient takes no medications and urine toxicology screen for illicit substances were negative. Non-contrast head CT was normal. This makes hemorrhagic stroke or large mass unlikely. But of course, CT is too rudimentary to evaluate for smaller lesions. Complete blood count, comprehensive metabolic panel, and urinalysis were normal. So, acute toxic metabolic derangement is less likely. There is no evidence of traumatic head or brain injury or central nervous system infection. At this point, our patient is back to her neurologic baseline. The next order of business is to identify a seizure focus. And the two common tools at our disposal are brain imaging and electroencephalography. Let's start with imaging. Here is an illustration of a coronal cut through temporal lobe. This will help us review our patient's MRI. In the midline, we have the pons, thalami around the third ventricle, and corpus callosum in the roof of the lateral ventricle. And moving laterally, there is the internal capsule and hippocampus head, which is within the temporal lobe. And this is our patient's MRI, a so-called epilepsy protocol MRI, a group of coronal sequences that will help identify epileptogenic lesions. This is the T2, coronal cut through the temporal lobes. Temporal lobe is the most common location where focal seizures originate, probably because hippocampus is highly electrically active. So patient is looking at you, and the patient's left is on your right. Is there any asymmetry between the two sides? How's the hippocampus? Yes, the left hippocampal head is sclerosed and smaller than the right, and there is compensatory enlargement of the temporal horn of the left lateral ventricle. Hippocampal sclerosis is also called mesial temporal sclerosis, as in scarring from an idiopathic gliotic process. That's a way of saying we're not sure why it happens. And we diagnosed our patient with a left temporal focal seizure, and now we have confirmed a lesion that correlates with that seizure focus. Mesial temporal sclerosis is not the only pathology that may cause seizures. Here's another example. This is focal cortical dysplasia, a malformation of cortical development. Now, this is a vascular lesion. This is a cavernous venous malformation, or cavernoma for short. This is a vascular malformation consisting of a cluster of dilated, thin-walled capillaries. Don't worry about knowing this. Just remember that a vascular abnormality can irritate the cortex and cause seizures. An infectious example this time. This is cysticercosis, a common cause of seizures worldwide. Larvae of this tapeworm can be imaged with MRI. In this patient's left temporal lobe, there is a rim-enhancing scolex, anterior end of the tapeworm, surrounded by hypointense cyst. And finally, a neoplastic example. This is a FLAIR image, axial cut, showing a hyperintensity in the left temporal lobe. This turned out to be an astrocytoma. Don't worry about being able to identify these pathologies on imaging just yet. Just remember that major categories of epileptogenic lesions include encephalomalacia and gliosis, like mesial temporal sclerosis, malformations of cortical development, vascular lesions and vascular malformations, CNS infections, tumors, and even immune-mediated lesions. This is a patient with a neurosarcoid lesion. The bigger point here is that all these example lesions are within the left temporal lobe. So the types of seizures with which these patients presented are likely similar. Clinical presentation depends more on lesion location, not pathology. Let's say we see a lesion on MRI. Or worse yet, there is no visible MRI lesion. EEG is a great tool to help confirm that clinical signs and symptoms are due to seizures. It can also help identify an epileptogenic lesion. You certainly won't be asked to read EEGs at your stage in the training, so feel free to skip this section if you want. But you'll be asked to remember some important EEG patterns. You can try to memorize them, or you can try to understand them. That's the purpose of this discussion. Let's bring back an image of a left temporal glioma. By convention, we look at scans from below, so that patient's left is on your right and the patient is looking upward. Let's flip the image to look at the top of the patient's head and replace it with an illustration with EEG electrodes attached. FP is for frontopolar, F is for frontal, T is for temporal, C is for central, P is for parietal, and O is for occipital. Odd electrodes correspond to the patient's left hemisphere, and even electrodes to the right. Here is a simplistic version of a standard clinical EEG. Electrode chains correlate to the amplitude and frequency tracings. The tracings trend differences in electrical potential across the electrodes. The top lines are lateral electrode chains, the odd left followed by the even right. For example, FP2, F8, T4, T6, O2 correspond to this patient's lateral right hemisphere. The next block of tracings are paramedian electrode chains. And finally, central electrodes. Usually, there are multiple additional control electrodes, like EKG. Each vertical column illustrates 1 second of recording. In the normal awake adult with eyes closed, the rhythm in the parietal occipital region should be 8 to 13 peaks per second. This is so-called alpha, or posterior dominant rhythm. If you count the peaks in this patient's P4O2 tracing, you get 10. So this is a 10 Hz rhythm, which is normal. Frequencies lower than 8 are considered slowing of activity. The frequency of this example is 6. Slowing could be focal in a particular area of the brain or generalized to both hemispheres. Unfortunately, slowing is not a very specific finding and can be seen after seizures, with focal structural lesions, even in patients without seizures, with toxic metabolic derangements, sedative medications, and neurodegenerative conditions. In patients with focal seizures, focal slowing may help localize the seizure focus. What we really hope to catch are epileptiform discharges. Sharp waves, spikes, spike and waves, polyspikes, or polyspikes and waves. What is the diagnostic accuracy of an EEG? Well, a routine or spot EEG is typically a 20 to 45 minute recording. It's obtained when a patient is not seizing in the interictal period. Interictal epileptiform discharges are found about 30% of the time, and the sensitivity is highest when the EEG is done in the first 24 hours after seizure or after a period of sleep deprivation. Now, extend that EEG to a continuous recording over a 24-hour period or longer, and your chance of finding interictal epileptiform discharges increases to over 80%. So, 20-minute EEG is good, but a 24-hour EEG is much better. Specificity of EEG is excellent. Interictal epileptiform discharges may show up in up to 6% of healthy adults and children. So EEG is false positive about 6% of the time. But if clinical history is suggestive of seizure, the specificity of EEG is over 90%. Let's get back to our case and to the central question. This is a 35-year-old woman who developed a single unprovoked 1-minute seizure. MRI and EEG confirmed a left temporal epileptogenic focus. What is the risk of seizure recurrence? When the probability of seizure recurrence is high, the patient is said to have epilepsy, a predisposition to generate epileptic seizures. By the way, most single unprovoked seizures do not recur. Only about 1/3 would develop another seizure within 1 year after their first. Who then is thought to have epilepsy? International League Against Epilepsy defines epilepsy as at least 2 unprovoked seizures at least 24 hours apart, or 1 unprovoked seizure with high estimated risk of recurrence, greater than 60% over the next 10 years, as defined by correlation between clinical picture, abnormal MRI, and EEG, or presence of a specific epilepsy syndrome. An epilepsy syndrome is a certain constellation of seizure types, clinical features, EEG findings, and comorbidities. A diagnosis of epilepsy predicts high risk of seizure recurrence. And high risk of seizure recurrence generally means treatment with antiseizure medications. And speaking of treatments, you can't make the proper treatment choices before understanding a person's epilepsy type. Epilepsy classification follows the seizure classification. We have focal onset and generalized onset seizures, which translate to focal and generalized epilepsies. If patients have a history of both types of seizures and their interictal EEG shows both generalized and focal discharges, then they have combined epilepsy. Combined epilepsy is more rare. Epilepsy type does not immediately translate to pathology. Pathologies causing epilepsy are broadly subdivided into 6 groups. You've already seen some of these when we discussed imaging. Structural causes like chronic strokes, tumors, focal cortical dysplasia, and so on. Structural lesions are the most common cause of focal epilepsy in adults and are usually visible on MRI. CNS infections like neurocysticercosis, which are the most common cause of epilepsy worldwide. Genetic variants that lead to structural brain changes. A known metabolic disorder like inborn errors of metabolism. There are over 200 of those. And autoimmune disorders. By the way, here we're not talking about acutely symptomatic seizures that happen with acute stroke, brain trauma, or encephalitis. Those are considered provoked. But some of the same brain injury that causes provoked seizures can cause permanent cortical damage, which leads to seizures later in life. The final level of classification is epilepsy syndromes. Epilepsy syndromes are defined by a unique combination of clinical features and EEG patterns. Many of these syndromes begin in childhood, many include generalized or combined epilepsy types, and many have genetic basis. So childhood onset epilepsy tends to be more syndromic, and adult onset epilepsy tends to be more focal. And the 3 epilepsy syndromes to know are juvenile myoclonic epilepsy, childhood absence, and epileptic encephalopathies, which include infantile spasms and Lennox-Gastaut. Just a few important facts about these syndromes. In juvenile myoclonic epilepsy, seizures start between 12 and 18 years of age. The prototypic seizures are myoclonic jerks. These are lightning-like synchronized muscle contractions. Myoclonic jerks are a manifestation of generalized seizures, and these seizures are most prominent in the mornings on awakening. Interictal EEG typically shows normal background activity with generalized polyspike wave fragments. Childhood absence epilepsy starts between 3 and 10 years of age. The defining seizure type is the generalized absence seizure. Seizing child suddenly stops responding for less than 30 seconds
Tyler.
and then returns to baseline almost immediately without a
Tyler.
postictal state.
Tyler, you can stop. Tyler.
What?
Hi. You got to show people what it's like. Tyler. Tyler.
Wait, what?
Do you remember how absence is different from focal seizure with impaired awareness? I'll leave that for you to review. During the absence seizure, EEG shows a sudden onset of generalized rhythmic spike wave discharges at approximately 3 per second. Brain imaging in both of these syndromes is usually normal. Developmental epileptic encephalopathies are a group of epilepsy syndromes that usually have lifelong, often drug-resistant and frequent seizures, which are associated with developmental delay and often severe intellectual disability. Infantile spasms start in infants less than 2 years of age. There are generalized seizures. Spasms are symmetric, sudden, and very brief contractions of the neck, trunk, and limbs. Most spasms happen in clusters, usually during waking hours. A normal background brainwave pattern on EEG is replaced by a chaotic, disorganized pattern consisting of random, high-amplitude, slow waves and spikes in all cortical areas. This disorganized rhythm is called hypsarrhythmia. Most children with Lennox-Gastaut usually present before age 8. Many cases evolve into this syndrome from other epilepsy syndromes, particularly infantile spasms earlier in life. Basically, any seizure type is possible here. Interictal EEG shows a generalized, slow, less than or equal to 2.5 Hz spike and wave pattern. The cause of these epileptic encephalopathies is unknown, but we think the culprit is a catastrophic insult to the brain at a critical point in brain development. For example, if blood flow in the umbilical cord is compromised, the brain may suffer diffuse hypoxic ischemic injury. So, brain imaging in these syndromes is usually abnormal. Okay, what about our 35-year-old woman who developed a single, unprovoked 1-minute seizure with MRI and EEG confirming a left temporal epileptogenic focus? What is the epilepsy type? That's right. This is focal temporal lobe epilepsy due to a structural lesion, mesial temporal sclerosis. Okay, we determined that our patient had a seizure. We identified the seizure type. We estimate the risk of recurrence to be high and diagnosed our patient with focal temporal lobe epilepsy. Time to consider antiseizure treatment. The choice to treat is more straightforward than the choice of treatment. So let's start with the synapse. Here is the presynaptic neuron. It could be a neuron that secretes glutamate, which produces excitation postsynaptically through sodium and calcium channels. Or it could be a neuron that, in conjunction with astrocytes, releases gamma-aminobutyric acid, GABA, which produces inhibition postsynaptically through a chloride channel. Antiseizure medications either inhibit glutamate release or its effects, or prolong effects of GABA. We'll use this synapse as a map to plot out our most important drugs. Voltage-gated sodium channels are blocked by phenytoin, carbamazepine, oxcarbazepine, and eslicarbazepine, lacosamide, cenobamate, lamotrigine, zonisamide, rufinamide, topiramate, valproate. Levetiracetam and brivaracetam affect release of glutamate vesicles by interacting with synaptic vesicle glycoprotein 2A. Vigabatrin inhibits GABA transferase in the astrocytes. More GABA, more inhibition at the synapse. Gabapentin and pregabalin inhibits the action of presynaptic calcium channels. Tiagabine blocks GABA reuptake from the synapse. Postsynaptically, benzodiazepines, valproate, barbiturates, topiramate, cenobamate, and cannabidiol augment action of GABA receptors. Perampanel and topiramate inhibit the AMPA sodium channel. Felbamate inhibits the NMDA sodium and calcium channels. Ethosuximide, zonisamide, and valproate inhibit the T-type calcium channels. You might have noticed that some anti-seizure drugs affect only one channel or receptor. They are so-called narrow spectrum. For example, carbamazepine only blocks the voltage-gated sodium channel, and some drugs have multiple mechanisms of action. They are so-called broad spectrum. Valproate is a good example of such a drug. Why are we talking about drug mechanisms? Because drug mechanisms matter. Narrow spectrum anti-seizure medications like oxcarbazepine treat focal epilepsy, but they may exacerbate generalized seizures. And broad spectrum anti-seizure medications like levetiracetam are effective against both focal and generalized onset seizures. So why not use broad spectrum drugs for all epilepsies? We certainly can, and we do. But in general, we should choose the drug that provides maximal efficacy with minimal side effects. Levetiracetam is not the answer for everything. And speaking of side effects, regardless of the mechanism, anti-seizure medications are all designed to interfere with neuronal firing. Two of the most active areas in the brain are the medial temporal lobe, hippocampus, and the coordination system, cerebellum. It's not surprising then that patients complain of short-term memory difficulties and coordination system dysfunction. The main offenders in this category include topiramate, benzodiazepines, phenobarbital, and levetiracetam. Behavioral effects. The award in this category goes to two drugs, levetiracetam and perampanel. Levetiracetam causes a spectrum of behavioral side effects ranging from irritability and hostility to depression, anxiety, and psychosis. Perampanel actually carries a black box warning for causing aggression and hostility. On the opposite end of the spectrum, lamotrigine and valproate are often used as mood stabilizers. Toxic anti-seizure medication metabolites may evoke an immune response. This immune response can range from benign skin rashes to Stevens-Johnson syndrome and, the more severe, toxic epidermal necrolysis, extensive necrosis and detachment of the epidermis. These patients are at high risk of bacterial infections and septic shock. It is terrible, but thankfully rare. Many older anti-seizure medications have skin reactions, but lamotrigine takes the crown in this category. Lamotrigine requires a very slow titration to avoid a rash. Runner-up, cenobamate is associated with DRESS syndrome, drug reaction with eosinophilia, and systemic symptoms. Teratogenicity. Valproate wins this category by a wide margin. Dose-related risk of major malformations is over 30%. Valproate should be avoided in patients who can become pregnant. So what do we use in those patients? Lamotrigine. This drug is associated with one of the lowest rates of teratogenicity. Many anti-seizure drugs are associated with hematological disorders, ranging from mild thrombocytopenia or neutropenia to full-blown bone marrow failure, aplastic anemia. This is the reason that patients need to be monitored with complete blood count at least every 6 to 12 months. The nominees in this category are felbamate, carbamazepine, and ethosuximide. And the winner is felbamate, with a rate of at least an order of magnitude higher than that of the runner-up, carbamazepine. The two drugs known for causing hyponatremia are oxcarbazepine, more likely, and carbamazepine, less likely. These medications induce a syndrome of inappropriate antidiuretic hormone secretion, SIADH, endocrine dysfunction, and weight gain. Valproic acid is the main offender that causes weight gain. Topiramate has the opposite effect and contributes to weight loss, probably because it reduces appetite and interferes with the efficiency of energy utilization. Vigabatrin is the only anti-seizure drug known to cause loss of ganglion cells in the retina. Patients experience progressive and permanent peripheral vision loss. Patients on vigabatrin require frequent ophthalmological follow-up. Next, hepatic metabolism and drug-drug interactions. Older medications like valproate, phenytoin, carbamazepine, and phenobarbital are known for this effect. Valproate is a potent enzyme inhibitor. Phenytoin, carbamazepine, phenobarbital are potent hepatic enzyme inducers. Now, the newer levetiracetam has fewer drug-drug interactions because it's not metabolized by the liver. Affordability is not really a medication side effect, but no less serious. Cost of drugs is a problem that is not exclusive to anti-seizure medications. So why are we talking about it here? With each new anti-seizure drug generation, efficacy stays the same, but it's the toxicity that improves. Also, the FDA's standard bioequivalence range of plus or minus 20% for generics as compared to brand name drugs appeared to be too broad for many anti-seizure medications. Brand name drugs may be more effective than generics. So, costs may limit access to the drugs with better side effect profiles. Here is our conception of pharmacological treatment choices. This is merely an evidence-based guideline. It does not include all the drugs, and it's not the only way to treat. For focal onset seizures, even those that spread to bilateral tonic-clonic activity, lamotrigine, levetiracetam, oxcarbazepine, and lacosamide are reasonable first choices. Zonisamide is rarely the first choice agent because of cognitive slowing and difficulty with concentration. The older GABA-A receptor blocker clobazam and voltage-gated sodium channel inhibitor phenytoin are also second line. Valproate works, but should be avoided because of its side effects. What are those, by the way? Right, teratogenicity, weight gain, and drug-drug interactions. For generalized onset tonic-clonic seizures, first-line treatment options include lacosamide, levetiracetam, zonisamide, and lamotrigine. Notice that all these drugs are broad spectrum, as signified by the asterisk. Clobazam, topiramate, and valproate are second line. We wanted to avoid valproate for focal epilepsy because of its many serious side effects, but it's one of the most effective broad-spectrum drugs for the treatment of generalized epilepsies. So, benefits outweigh risks. Remember how I said that generalized epilepsies need broad-spectrum anti-seizure drugs? One notable exception is the narrow-spectrum T-type calcium channel blocker, ethosuximide, which is effective in generalized childhood absence epilepsy. Valproate, lamotrigine, and levetiracetam could be used as second line. We should avoid narrow-spectrum drugs like the voltage-gated sodium channel blockers, oxcarbazepine, carbamazepine, eslicarbazepine, and phenytoin, because they may actually worsen generalized seizures. And finally, for myoclonic generalized seizures, like the one seen in the syndrome of juvenile myoclonic epilepsy, levetiracetam, valproate, and lamotrigine are first line. Second-line drugs include benzodiazepines, clobazam, perampanel, and topiramate. Once again, we try to avoid narrow-spectrum medications as they may worsen myoclonic seizures. Stare at this chart for a second. Notice that the L drugs are often on top. I'm talking about lamotrigine, levetiracetam, and lacosamide. They are a good first or second choice for most epilepsies, and they're usually well tolerated. Okay, now that we have a laundry list of drugs and a list of side effects, let's apply this knowledge to some examples. A 65-year-old man with bipolar disorder and obesity suffered head trauma after a severe car accident. Post-trauma, he developed headaches, mild cognitive impairment, and focal epilepsy. His seizures are rare, once every 2 to 3 months. What would be a reasonable first treatment choice? Lamotrigine would be a good choice. Lamotrigine will treat his bipolar disorder and will not cause weight gain or worsen cognitive impairment. It should be titrated slowly to avoid a rash, but his seizures are rare, so slow titration should be okay. You know what's not a good choice here? Levetiracetam. Because of those behavioral and cognitive side effects. How about this situation? A 21-year-old woman, college student with a history of normal growth and development. She developed brief episodes of full body stiffening and shaking with loss of consciousness that usually occur without warning. She was initially treated with oxcarbazepine, but the episodes increased in frequency. During epilepsy monitoring, she had recurrent myoclonic jerks with corresponding generalized spike and wave discharges. She's otherwise healthy and doesn't have headaches or mood disorders. What would be a reasonable first treatment choice? She has generalized myoclonic epilepsy, juvenile myoclonic epilepsy, which was difficult to diagnose. In hindsight, it's easy to see why narrow-spectrum oxcarbazepine worsened her seizures. Topiramate and lamotrigine may be reasonable, but topiramate will cause cognitive slowing and she needs to keep up with her coursework. Lamotrigine requires slow titration to avoid a rash, but her seizures are frequent and she needs a drug that will be effective faster. Levetiracetam becomes a reasonable choice. Valproate is very effective in generalized epilepsy, but this person has potential to become pregnant. Valproate is teratogenic, so it would not be the first thing we try. Now, what about our patient? She's a 35-year-old previously healthy woman who developed generalized tonic-clonic seizure preceded by temporal lobe aura. MRI and EEG led to a diagnosis of focal temporal lobe epilepsy. What's the most appropriate anti-seizure medication? I should mention that she's an engineer and her job is hectic and involves highly technical cognitive tasks. This is a focal onset epilepsy, so we have a few reasonable choices here. Lamotrigine, levetiracetam, oxcarbazepine, and lacosamide. This is a tough one. The temptation is to just reach for the broad-spectrum levetiracetam. What are the advantages? This drug is renally cleared, so it has fewer drug-drug interactions. It does not need to be titrated. Efficacy is already maximal at the initial loading dose, so it's suitable for patients with uncontrolled seizures. What is the major disadvantage? Behavioral side effects, depression, anxiety, and rarely psychosis. Okay, levetiracetam is a contender. What about lamotrigine? What are the advantages? Lamotrigine is less sedating and has fewer cognitive adverse effects than traditional anti-seizure medications. Lamotrigine has one of the lowest rates of teratogenicity. Lamotrigine also has beneficial effects on mood, and mood disorders often coexist with epilepsy. Disadvantages? Lamotrigine needs to be titrated slowly to avoid a rash, so lamotrigine takes longer to reach effective dose. This is not the best choice for people with active, frequent seizures. Lamotrigine is also extensively metabolized in the liver, so there is higher potential for drug-drug interactions than with levetiracetam. Okay, what about the voltage-gated sodium channel blocker, oxcarbazepine? This drug can be titrated quickly and is relatively well tolerated. The downsides? Oxcarbazepine is more likely to cause hyponatremia because of inappropriate antidiuretic hormone secretion. And oxcarbazepine is a mild enzyme inducer, which is generally not a problem, but at higher doses, it can affect estrogen metabolism and decrease the efficacy of oral contraception. And what about lacosamide? Lacosamide enhances slow inactivation of voltage-dependent sodium channels and inhibits repetitive neuronal firing. It's effective against non-convulsive seizures like those arising from the temporal lobe. Also, intravenous formulation is available for patients who cannot swallow, especially if they're cognitively impaired because of frequent seizures. But lacosamide may prolong PR interval and worsen heart block. There is no one right answer here. Based on the discussion with the patient, levetiracetam was chosen. Fast forward 12 months. Patient is strictly adherent to levetiracetam. Her seizures have improved, but she continues to report one seizure every 1 to 2 months. Bilateral tonic-clonic seizures are rare, but still prevent her from driving. She's concerned about maintaining her employment. We need to change our treatment strategy. The treatment of challenging cases is for the experts and outside the scope of this review. But let's consider some general guidelines. First, has the patient really failed monotherapy? Maybe the choice of drug was inappropriate for the epilepsy type. That's not the case here. Levetiracetam is a good choice for focal temporal lobe epilepsy. Maybe the treatment adherence is challenging? No. Our patient's serum drug levels showed adherence. Was the target dose too low? This is especially important for drugs that are metabolized in the liver because of multiple drug-drug interactions. The dose for our patient was appropriate, but let's say there's some room to increase the dose. That brings us to our second consideration. The maximal dose is often limited by the side effects. At this point, adding another drug allows us to reduce the dose of the first drug, reducing bothersome adverse effects. Higher doses of levetiracetam may cause sedation and behavioral side effects. Let's consider adding another anti-seizure medication, which means 3. It's most rational to combine drugs with different mechanisms of action, or combining narrow spectrum with broad spectrum drugs. Adding a narrow spectrum voltage-gated sodium channel blocker, oxcarbazepine, to our patient's broad spectrum synaptic vesicle protein 2A binding levetiracetam is reasonable. But adding oxcarbazepine to lacosamide, 2 sodium channel blockers, is a bad idea. poor additional efficacy, and double the side effects. And the final point. When combining anti-seizure medications, there is such a thing as law of diminishing returns. If you take 100 patients with epilepsy and start an anti-seizure drug, about half of them will become seizure-free. If you add a second drug, only 12% more will be seizure-free. Adding a third and fourth anti-seizure agents only increases the chance of seizure freedom by 1% each. That's the law of diminishing returns. For our 35-year-old woman diagnosed with focal temporal lobe epilepsy due to hippocampal sclerosis, having failed her first medication, oxcarbazepine was added to levetiracetam. Our patient was doing well for a time until she developed gastroenteritis. She had diarrhea and vomited several times, and just when she was getting better, she smelt the familiar burnt smell and tasted metal. As soon as she sat down on the ground, she lost consciousness, stiffened briefly, letting out a ghastly cry, and began to shake. One generalized tonic-clonic seizure, followed another, and then another, without her regaining consciousness. This is status epilepticus, and it's a neurological emergency. Convulsive status epilepticus is defined as at least 5 minutes of continuous convulsions, or at least 2 seizures between which there is incomplete recovery to consciousness. Time is brain principle is crucial in convulsive status epilepticus, just like with acute ischemic stroke. Ongoing seizures beyond 30 minutes pose a significant risk of permanent neurologic injury. So, rapid, aggressive treatment of status is a must. Just like with any neurological emergency, we start with the ABCs: airway, breathing, circulation. We have little time to get brief focused history and rapidly address any causes of status. And speaking of history, we specifically want to know history of epilepsy, including current anti-seizure medications, recent factors that could have precipitated seizures, like illness or medication changes, and for people who had status epilepticus before, history of response to treatment. As you recall, our patient's temporal lobe epilepsy was treated with levetiracetam and oxcarbazepine. She developed gastroenteritis, and this is her first episode of status epilepticus. Because time is brain, it's always important to know how long a patient has been seizing. Onset of status is not always witnessed, and in the case a person is found seizing, we use the time of last seen well to estimate the duration of status. In our case, onset was witnessed. Let's treat. First, we start with benzodiazepines. 10 milligram of midazolam is a great option. It's usually given intramuscularly by the paramedics. Intranasal and buccal forms of midazolam can be given at home. 20 milligram of rectal diazepam is an alternative. Once intravenous access has been established, we move on to intravenous lorazepam, 2 to 4 milligrams to start. And if the seizures continue, then redose up to a maximum of 0.1 mg per kg. So a 70 kilogram person may receive up to 7 to 8 milligram of lorazepam. I promise that this is the only time we'll make you memorize doses of drugs. Because guess what? One of the major problems in the treatment of status is underdosing. Benzodiazepines will not stop status epilepticus in up to 1/3 and will eventually cause sedation. Here, patients usually get intubated, primarily for airway protection, and we proceed to the second-line anti-seizure drugs. 60 milligram per kilogram of levetiracetam, up to a maximum dose of 4.5 grams, 40 milligram per kilogram of valproic acid up to a maximum of 3 grams, or 20 milligram per kilogram of phosphonatoin, 1.5 to 2 gram load. Phosphonatoin is safer than phenytoin. 60-40-20. Easy to remember. There's also some evidence for 400 milligram of intravenous lacosamide given over 5 to 10 minutes. By the way, if benzodiazepines abort the seizure and the patient is not intubated, you must absolutely administer a second-line agent anyway. Benzodiazepines will wear off, and without a longer-acting anti-seizure medication on board, you will be right back where you started. If the patient continues to seize, having failed 2 agents, status epilepticus is now considered refractory. Longer seizures are less likely to stop spontaneously. They are less responsive to anti-seizure medications, and they carry higher risk of long-term sequelae. Time to get even more aggressive. Next step, general anesthesia, midazolam or propofol. Continuous infusion of midazolam is preferred here, since it's a bit safer than propofol. The patient needs to be intubated for this treatment, and inducing paralysis is necessary to intubate, so patients will stop shaking, but the seizure activity may still continue. You need continuous EEG monitoring to tell. So status epilepticus cannot really be managed effectively without continuous EEG monitoring. If status persists beyond 30 minutes or recurs after 24 hours of treatment, it is now considered to be super refractory. The evidence for what to do here is limited. This is the last resort, the everything and the kitchen sink of status management. Some of the options are inducing a coma with high-dose barbiturate, pentobarbital, to essentially press reset on brain activity. Pentobarbital has a very long half-life. It takes days to weeks to wean, so you won't know if your treatment is successful for a while. Another option is using NMDA receptor antagonist ketamine that blocks the action of excitatory neurotransmitter glutamate. The final option is cooling the body, therapeutic hypothermia. These and other treatments of refractory status are beyond the scope of this talk. So what happened to our patient? Paramedics administered 10 milligrams of midazolam. In the emergency department, she then received 4 milligrams of lorazepam and 3.5 grams intravenous load of levetiracetam. Levetiracetam was effective for her seizures in the past. Seizures stopped, but benzodiazepines unfortunately caused sedation, and she was intubated. Once intubated, the anesthetics needed to be continued for her patient's comfort. Continuous EEG thankfully showed no further seizure activity. She was weaned off anesthesia after 2 days, extubated, and ultimately discharged home. But before we discharged her, we asked ourselves one very relevant question. Why did she suddenly develop status epilepticus? And what are the causes of status epilepticus anyway? In adults, the common causes are low anti-seizure medication levels because of missing doses or underdosing, structural brain lesions, usually because of cerebrovascular insults or hypoxic injury, metabolic derangements, and alcohol-related issues, especially alcohol withdrawal, systemic infections and sepsis, and intracranial tumors. In children, I would add fevers to the list. In a child aged 6 months to 5 years, a single brief generalized tonic-clonic seizure with a fever is usually benign. That's a simple febrile seizure. But outside that age range, febrile seizures may be serious, especially if they're focal and especially if they're multiple. Uncommon causes include immune-mediated disorders like autoimmune encephalitis. We're diagnosing these more and more often. CNS infections, genetic disorders, mitochondrial disorders, and seizures as a result of drugs or toxins. Which of these caused our patient's status? Right. She had gastroenteritis and likely kept vomiting out her anti-seizure medications. Our patient returns to the clinic after her hospitalization. You're reviewing the chart. Temporal lobe epilepsy, poorly controlled with levetiracetam and oxcarbazepine, had an episode of status epilepticus, neurological exam is nonfocal. She's understandably concerned that her seizures are not under control, and going through that episode of status was terrible. She asks us, are there any other treatment options? Should we add a third anti-seizure drug? Remember the law of diminishing returns? Adding that third anti-seizure drug makes little difference. By the way, are you shocked that our patient has drug-resistant epilepsy? Epilepsy that's not controlled despite 2 drugs? Not really. Even despite multiple medications, seizures remain uncontrolled in up to 40%. And this brings us to the last part of our talk: surgical treatments. Brain surgery is a daunting concept for most people, and who can blame them? As with any treatment, especially invasive one, it's a good idea to start with risk-benefit analysis. Let's start with the risks. Surgery typically involves resecting or lesioning a temporal lobe, the most common location of focal seizures in adults. So we risk causing signs and symptoms of temporal lobe damage. For example, injuring inferior optic radiations, Meyer's loop, that travel through the temporal lobe may cause contralateral superior visual quadrant defects. Dominant temporal lobe contains receptive language centers, and damage there may cause aphasia. Less than 1/3 of patients develop some degree of memory loss because the hippocampus is lesioned. And few patients develop depression. Finally, perioperative side effects like bleeding and infection may be expected with any surgery. Thankfully, those are rare. Overall, epilepsy surgery is safe, especially since nowadays we have very precise techniques like stereotactic laser thermal ablation. Here, MRI is capturing heat changes in the brain tissue to show the amount of tissue destruction being done by the laser. Red and yellow colors show temperatures over 70 degrees Celsius. Let's weigh those risks against the benefits. Epilepsy surgery is effective at providing seizure freedom. How effective? Very. Up to about 65% of patients are essentially cured. And even if surgery doesn't result in a cure, up to 9 out of 10 people experience a dramatic reduction in seizure frequency, which means we can lower anti-seizure medication levels and decrease unwanted drug side effects. How many treatments in medicine promise a 65% chance of a cure? In study after study after study. But this is old news at this point. If a surgery is being done specifically to remove a lesion that was identified with MRI, like hippocampal sclerosis, tumors, or malformations of cortical development, the chances of seizure freedom increase 2.5 times. The other benefit of epilepsy surgery is decreased mortality, specifically decreased risk of sudden death in epilepsy, SUDEP. This is a phenomena that is presumably caused by cardiac arrhythmias, respiratory dysfunction, or neurogenic cardiorespiratory depression in the setting of a seizure. We're not talking about death as a result of status epilepticus or traumatic injury or drowning because of seizure. We're talking about a patient developing cardiorespiratory compromise in their own bed during sleep. Even a single seizure can be deadly. Thankfully, this is very rare. But still, one thing's for certain, The more uncontrolled the seizures, the higher the risk of SUDEP. Selecting patients for epilepsy surgery is a complicated process. It's best left to the experts in qualified epilepsy centers and beyond the scope of this talk. But it's worth knowing what an ideal epilepsy surgery candidate looks like. This patient would have refractory epilepsy. They would continue to have frequent seizures despite 2 well-chosen and appropriately dosed medications. The seizures should be focal onset and related to a lesion that is seen on imaging. A lesion that we can see can be more easily removed surgically. This lesion should correlate with clinical history and seizure focus on EEG. Oh, and there should be a single focus. And finally, the lesion plan for resection should not involve eloquent cortex, like language center, visual pathways, motor pathways, so that the risk of post-op neurological deficits is minimized. For people who don't qualify for resection, there are other good options. Responsive neurostimulation, RNS, is a closed-loop system that can detect seizure activity with intracranial EEG electrodes and then stimulate the brain to modulate it. Deep brain stimulation is an open-loop therapy that delivers continuous current to the thalamus to raise the seizure threshold. Vagal nerve stimulator resembles a cardiac pacemaker and delivers intermittent electrical impulses to the left vagus nerve. We don't really know how exactly that decreases seizure activity, but it does. Bottom line, surgical resection is more effective than these neuromodulation therapies, at least with current technologies. Maybe at some point, science fiction will catch up with science fact, and these devices will become first-line treatment. One can dream. So, what happened to our 35-year-old woman with focal temporal epilepsy caused by hippocampal sclerosis? Having failed multiple anti-seizure medications, she had an uncomplicated ablation of the left medial temporal lobe. And for that past year, she has had no more seizures. Yay! We would still keep her on anti-seizure medications for a bit, but at least we were able to reduce the doses.
Thank you, Dr. Hun. You're still here? I can't believe it. This is the 10% of the stock that you absolutely need to know. So let's review the approach. Patient complains of episodes of transient neurological dysfunction, shaking, behavioral arrest, confusion, loss of consciousness. Not every episode of transient neurological dysfunction is caused by a seizure. So first, we must decide if seizure is a possibility. History is often fairly nonspecific and unhelpful, but what would really get you thinking about seizures is if the events are stereotypic, happen the same way, brief, have postictal confusion, are associated with a lateral tongue bite, and occur in a person with risk factors for epilepsy. Let's say you're convinced that a seizure is a strong possibility. Was it focal or generalized? Many seizures in adults older than age 25 are focal onset, and temporal lobe is the most common seizure focus. This is where detailed history of the aura, ictus, and postictal state would really help. Auras of déjà vu, rising epigastric sensation, funny smells or tastes are usually temporal. Aura of intense fear is usually frontal. Ictus that starts with behavioral arrest and automatisms is usually temporal. Gaze and head deviation, tonic posturing like a fencer's posture, and vocalizations are usually frontal. Focal neurological deficits postdictally may also be a clue to a seizure origin. For example, Todd's paralysis of the left side is suggestive of right frontal involvement. Just remember that seizures can spread between cortical areas, so it's the first symptom that the patient experiences that is most valuable. Good examples of generalized seizures include brief behavioral arrest without motor phenomenon or postictal confusion, a so-called generalized absence seizure, and myoclonic jerks. Generalized seizures do not present with an aura or automatisms or focality, and they're usually more frequent, especially in the case of absence. History will only take you so far, but ultimately you need diagnostic workup. Brain MRI epilepsy protocol, that includes coronal slices, and EEG. Workup serves three purposes: to confirm the likelihood that an event of transient neurological dysfunction was a seizure, to establish the seizure type, and to identify a causative lesion. Workup also helps estimate the likelihood of seizure recurrence. Next, we need to decide if the likelihood of seizure recurrence is high. In other words, is it epilepsy? 2 or more seizures that are not provoked by acute systemic or central nervous system injury would qualify. A single seizure with MRI and EEG showing a correlating seizure focus is also considered epilepsy. Epileptic risk factors like family history also increase the risk. And especially in children, look for syndromic presentations. High seizure recurrence means epilepsy, and epilepsy types parallel seizure types, which is important because diagnosing a patient with epilepsy usually means antiseizure drug treatment. And with respect to drug choice, follow several simple guidelines. Choose the drug that's most appropriate for epilepsy type. This means avoiding narrow-spectrum drugs like oxcarbazepine for generalized seizures because they may exacerbate those seizures. The L drugs, lamotrigine, levetiracetam, and lacosamide, are generally good choices for most epilepsies. Choose a drug that minimizes side effects while maximizing benefits. This is especially important with comorbidities. Lamotrigine is a good option for persons who may become pregnant or need mood stabilization. Topiramate is a good option with a comorbidity of obesity or migraines. Levetiracetam has low drug-drug interactions and is a good option for acute symptomatic seizures, in status epilepticus, and for patients undergoing chemotherapy, where significant drug-drug interactions are expected. When it comes to adding drugs, use rational polypharmacy and combine drugs with different mechanisms of action. Also, adding a second drug may help reduce the dose and therefore side effects of the first. With drug-drug combinations, there is a law of diminishing returns. When epilepsy is refractory despite 2 well-chosen and appropriately dosed drugs, it's time to consider epilepsy surgery. Surgery is very effective and safe. The ideal candidate for resection would have a single seizure focus that correlates with EEG findings and a lesion found on imaging, and lesion plan for resection should not involve eloquent cortex. If at any point during follow-up a patient develops a seizure that persists beyond 5 minutes, or multiple seizures in succession without returning to baseline in between, that is status epilepticus. First, the ABCs. Establish an airway and ensure hemodynamic stability. Now is also a good time to think about emergent causes of status, like low antiseizure drug levels, acute CNS injury, metabolic derangements. Abort seizures aggressively. Remember, time is brain. Start with intramuscular or rectal benzodiazepines in the pre-hospital setting, and in the hospital, continue with intravenous lorazepam and second-line antiseizure medication load. For example, levetiracetam. What's the dose? 60-40-20 milligrams per kilogram, depending on the drug. Do not underdose. If the status becomes refractory, intubation and anesthetics may be necessary. But still, do not neglect those second-line antiseizure medications. Anesthetics will need to be weaned at some point, and seizures will return. Because of high potential for deterioration, management of convulsive status epilepticus happens in an ICU setting and requires continuous EEG monitoring. And that's all for today. As always, thank you for your kind attention, and we'll talk again soon. Bye!